Hello all.
OK，请你回答一下。
Let me take this question. To answer this question, in my presentation, I have discussed with you overall for COVID-19 testing, the general principles are biosafety level 2 lab to conduct level 3 biosafety protection. This is the fundamental principle. And for suspicious samples, and we use this principle as well. And Dr. Sanka Sundaram mentioned the challenges they are dealing with. I cannot agree more with them because in the early phase of our laboratory testing, we face the same challenges. Because we have existing inpatients, we also have newly admitted COVID-19 patients at that time in our laboratory. We try to improve day by day. At the beginning, in our laboratory area, I suggest you for COVID-19 testing, try your best and to have a dedicated area for COVID-19 related testing. In this area, biosafety cabinet is a must. And during the testing, let's talk about the routine test for COVID-19. It includes blood routine, urine routine, CRP, and physiological chemical testing, and the PCT. These are basic clinical testing. For these test items, we try our best and to run all those tests in this dedicated COVID-19 only area so that we can reduce the protection for all the staff. Not every person needs to be reaching level 3 biosafety protection, and that would solve the challenge of, as Dr. Sanka mentioned, on the lack of human resource. On nucleic acid tests, this is another major part. For nucleic acid test in China, our requirements are very stringent. Theoretically, 3 zones, buffer zone. We need to have the reagent preparation zone, specimen preparation area, and amplification area. It also has a requirement on ambient pressure. So generally, in buffer area, the ambient pressure should be high. In amplification area, it should be negative pressure so that the contaminants would be excluded. So these are general principles. Level 2 laboratory, level 3 biosafety protection for staff. And given the actual situation of every hospital, we should arrange our work accordingly. Thank you very much. This is my answer. And I would like to add 2 points to this question. On nucleic acid test, as Professor Wang mentioned, in terms of levels, for COVID-19 patients confirmatory test, nucleic acid is very important. So it poses high requirements for laboratories to conduct the nucleic acid test. Usually those laboratories are in general hospitals or in central labs. So they might be well equipped and might be qualified to conduct the nucleic acid test, to run PCR test and genomic sequencing test. This is point 1. Point 2, for COVID-19 testing, it is actually for different specimens. We need to conduct a risk management for different specimen management, from refractory tract specimens to valve to sputums. These are the high risk because they are collected in the open airways. So on specimen management, the biosafety level should be the highest for those specimens collected from open airways, from refractory tract, including the when we use a bronchoscope, then this biosafety level should be the highest. This is our experience. Secondly, for specimens collected from the enclosed environment, such as blood specimens and urine specimens, relatively speaking, the risk level is lower than those collected from respiratory tract. This is my supplement. Thank you. And on the second question, does formalin fixation disinfect the virus? Does temperature affect the variability of the virus? Professor Wang will try to answer this question as well. Because in China, we might work in a different way than in India. In China, EP and CP are from different departments, and our experts are in China from CP. And this question is related to AP, related to pathology in terms of operation. So on this question, I've checked some references. According to Chinese Medical Association Pathology Committee, they issue the guideline. 10% of formalin fixation can disinfect the virus for inactivation. However, the fixation operation needs to be done at level 2 lab with level 3 protection for inactivation. After inactivation, then it can be done at a level 2 laboratory with level 2 protection. And this temperature affects the viability of the virus, because so far, our understanding on COVID-19 is based on our understanding on SARS and MERS. So with that experience, that SARS and MERS can be fully inactivated for 30 minutes under 56 degrees Celsius. So for PCR inactivation, we use that temperature requirement for inactivation. So this is my answer to these two questions. Thank you. Thank you. Any questions? The next question. What to do in case of accidental spillage of blood samples of COVID-19 positive patients? I would like to invite Professor Mao to answer this question. Thank you. For COVID-19 patients, when the blood specimen is spilled, according to China NHC's guidance on biosafety lab for COVID-19 testing, and the biosafety lab provisions by China's NHC, I would like to say, if the blood specimen of COVID-19 is spilled, when the table surface is contaminated, and we can use the 5,500 milligram chlorine-based disinfectant to disinfect the surface. So this disinfectant should be prepared within 24 hours before the usage. So we need to use a disinfectant to fully cover the contaminated surface and the spilled specimen for 30 minutes, and then use the wipe disinfection to wipe out, use the water-absorbing cloth to absorb the contaminants and transfer the contaminants to the waste bag and transfer it to autoclave for disposal. This is my answer. Next question. What are the hematological parameters which can help in diagnosis and prognosis of COVID-19? Which parameters help us in predicting worsening prognosis? Professor Mao, please. So hematological parameters do help. In my talk, as I said, In blood routine tests, we have many parameters, including lymphocytes counts, the NLR, and the neutrophil count, and the CRP, etc. All these parameters combined would be very helpful in COVID-19 prognosis. And NLR for COVID-19 severity detection, usually NLR of a severe COVID-19 cases would be much higher than NLR of a mild COVID-19 cases. So this is a parameter we should take into account. And also the lymphocyte count change as well. We also need to look at some other factors such as whether the age factor and diabetes in a comprehensive way. Also, the physiochemical index, such as the creatine, etc. This is also helpful as well. Our experience with the serological tests available on COVID-19 is a tool for preliminary testing before confirmation via PCR. Professor Wang, could you answer this question? To answer this question, actually, I noticed a lot of questions posted related to the antibody questions in the chat box. For antibody testing in China, because on March 3rd, in the 7th edition of clinical guidance published, many laboratories have started trying to use antibody testing for COVID-19. So we just tried that for 2 weeks. And the common understanding is that when we use IgG and IgM, it is not about screening. Because the test kit, in terms of sensitivity and specificity, the testing time is short. The IgM antibody testing, so far, this performance still need to be observed. And for the approved antibody test kits, it should be used for suspected cases combined with the PCR test result for confirmation. So for the antibody testing, my suggestion is that you need to look at the clinical manifestation, the epidemiology history, also with the PCR test to have the comprehensive judgment, because clinically, according to our observation, we also noticed that PCR test positive while antibody negative, or vice versa, among COVID-19 patients. So some patients might be during the window period, but for the nucleic acid test negative, and this is a false positive phenomenon. So for the serology test usage, we need to be precautious. You need to look at the clinical manifestations with close communication with physicians to let them judge if this is a false negative. Because in China, a positive patients will be treated and close contacts need to be medically observed. A lot of prevention and control measures will be taken. So if false negative happens, that the medical staff will be under great pressure. So we need to be precautious about using serology test. Very good answer. I agree with you. So for antibody testing, definitely is a good tool. However, in terms of the usage scenario, at least in China, we are not suggesting to use the antibody test kits as a screening tool. So I suggest our Indian colleagues to be precautious, to be careful about using that. for screening because the uncertainty of serology test is higher than PCR test. Especially the serology colloidal method, the uncertainty level is higher. So that's why we need to look at the clinical manifestations. In the previous editions of Chinese clinical guidance on COVID-19 diagnosis and treatment, it has mentioned that our clinical physicians should judge whether his patient are COVID-19 or not by looking at the clinical manifestations and epidemiology histories without looking at the PCR test. If conditions are appropriate, the physicians can decide to admit those patients. Of course, some patients are suspect cases without being infected by COVID-19, but with this approach, we can try our best and to a larger extent to could contain the epidemic. If we don't use the clinical method, but we use uncertain method, which is this serology test, the consequence is that the patient could be asymptomatic, and then the serology test is positive. For this group of people, if we quarantine them in medical institutes, then it is inappropriate, and that may lead to social unrest as well. So I completely agree with Professor Wang's opinion, and this is also our Chinese experience that we would like to share with Indian colleagues. Thank you. And the next question, how different is the progression of serological test in other viruses such as MERS, SARS-CoV, and SARS-CoV-2, and have you seen cases with co-infections? Professor Wang, I think that you must be very experienced with that. Please answer that. Thank you. I will try my best to answer this. For other viruses, because it is all viral infection, and during our diagnosis, we identify the generation of antibody and the IgG turning from negative to positive, or the IgG rises 4 times than the normal period. And all these are commonly well-acknowledged phenomenon. In China, only we are treating COVID-19 patients without treating SARS-CoV patients and MERS-CoV patients, and so I haven't seen any co-infections among them. But clinically, I do see COVID-19 patients with co-infections of influenza, and but this is rare. Another scenario I observed is that usually from November to the next March, it is the flu season in China. Over the past 3 to 5 years, during this period, every year we receive a high number of flu patients. This is a great pressure for our hospitals. But this year, what we notice is that the flu patients number was very low, and we are looking into that, trying to find out the answer as well. We guess probably it's because everybody's wearing masks in China, so that reduces the probability of flu, or patients are afraid of going to a hospital to be treated because of the COVID-19 outbreak. And for example, an expert from Shanghai said that everybody should be staying at home in China, so that the COVID-19 would vanish. So that might help as well. So this is different from what we experienced over the past few years. And usually we receive a high number of flu patients and during this period, but this year is very different.
I agree with you. And in our hospital, we have the similar situation. Back in 2003 and in this year, few patients are infected with both diseases. And the situation you've mentioned about flu, I think is very interesting. And there have been few cases for infection of SARS and COVID-19 at the same time. And this year, the outbreak, there hasn't been an outbreak, a widespread outbreak of flu. And actually, this has benefited our fight against COVID-19. I thank Professor Wang for your answer.